All right, so it looks like we've got some folks still joining, but we wanted to start with some housekeeping items. First of all, welcome. Thank you for joining the webinar. We are turning off camera, mics, and the chat. However, I want to direct you to our Mentimeter link that is in the chat. You'll be able to add your questions and comments through that, and we'll be sharing and responding to a lot of these questions at the end of the session, moderated by Sujita Ratnasingham. And additionally, we have the link to the report. If you're interested in seeing it, it's also in the chat. We will be recording this session, and the recording will be available on the ICES Ontario YouTube channel. For now, I will be passing along to our CEO, Michael Schul, to get us started.
Thanks, Naveen, and thank you everyone who's attending this webinar. I'm super excited to be kicking it off here this morning, and I'm looking forward to a very interesting conversation over the next hour or so. I want to start with a land acknowledgement. I am sitting in Toronto, and so the land acknowledgement that I give will reflect where I'm located, but I invite you to reflect on wherever you are located, and perhaps to offer your own land acknowledgement that would be relevant to where you're located. Toronto is a word that comes from Tikaronto, which is a Mohawk word and means the place in the waters where the trees stand. Tikaronto is the ancestral home of the Mississaugas of the New Credit, of the Haudenosaunee, of the Chippewa, of the Anishinaabe, the Huron-Wendat, and many other First Nations, Métis, and Inuit peoples that today continue to call Tikaronto home, or Toronto home, and we acknowledge their presence here on these lands for eons, and thank them for sharing those lands with us. I also want to thank all of you who have signed up and have shown up today to attend this webinar. I hope you're going to enjoy the remarks that you hear over the next 60 minutes or so, and I hope you have lots of questions for us, because we really want this to be an interactive dialogue. We want to be sharing, but also hearing and learning from you, and so we look forward to that conversation. We have a terrific lineup of speakers for you, and I'll just briefly introduce them here. We have Astrid Gutman, who is the Chief Science Officer at ICES. She's also a professor in the Department of Pediatrics at the University of Toronto. We have Laura Ferreira-Legere, who is a Senior Manager of Public and Community Engagement and Knowledge Translation at ICES. We have also Arjuman Siddiqui, who is a professor at the Dalhousie School of Public Health and is also a member of the ICS Scientific Advisory Committee. Finally, we will have Sujita Ratnasingham, who's the Director of Strategic Partnerships at ICS, who will moderate the Q&A session after the speakers have presented. And I do just want to take a moment to thank the other members of the core working group who contributed to the document, and some of whom you're going to probably hear from today during the Q&A. And so with that, I'm going to turn it over to Astrid to kick things off.
Thanks, Michael. Wonderful to see so many people at this meeting. So I am going to just present a little bit of context around this initiative. So we've developed what we're calling a framework for anti-racist research, anti-racist approaches to research and analytics at ICES. And there are four main components to this framework. The first is really to build capacity around anti-racist research. The second is to ensure that there's community access to data, that we develop community governance of those data, and finally, that we hold ourselves accountable for impact. And in terms of the genesis, I'm just going to give a little bit of context around how this came about, why now, or why, when we started. So there have been many calls in Ontario, more widely in Canada, for better data and the collection of data in order to address what we know are vast systemic health inequities, including those that are related to different forms of racism. And in 2021 in Ontario, the Black Health Equity Group, which of whom many of members had been advocating for this in Ontario for a long time, published their own framework called, it was the EGAP framework, Engagement, Governance, Access, and Protection, which really addressed how race data should be handled and governed and used to address health inequities, and called on institutions like ICES as a data steward of population-based health and demographic data to engage with this framework. This came on the heels of the brutal murder of George Floyd in the US the year before, and in the middle of a pandemic that just illustrated the horrendous inequities that have existed for a long time, but that were just so clear in terms of who was getting sick, who was dying of COVID, for all of these, a myriad of structural and systemic issues related to who does what kind of work, who has sick leave, who lives in what kind of housing, et cetera, et cetera. And at the same time, during COVID, for the first time, the Ministry of Health started an initiative to collect race and household income and other data for the COVID testing data. And that was the first time that we've seen a little bit more population-based data collection of these kinds of data, and those data we receive. And it just became clear for so many important reasons that we needed to wrap our minds around how we would work with data. But it became very, very clear early on that this wasn't just about data and data governance, but it was really about the kind of research that we did. And interestingly, we weren't the only ones grappling with this. So I would say there was a whole movement within the biomedical research complex to start thinking about racism in health and race data. And and this spurred many of the big journals, CMAJ most recently, but JAMA and New England Journal started to put together principles around this. And I would reflect that some of what needed to be said, race is a social construct. Race is not biology or genes. The social scientists must have looked at our entire field and thought, like, what's up, right? I mean, this is not new knowledge. They've known that for a long time. But I think what became clear to us as we thought about this and about the capacity is that, most of our scientists come from clinical epidemiology, health services research, fields that are not particularly theoretical and not particularly well equipped scientifically to really do deep research into racial inequities in health necessarily. And so that was part of the strategy, and Laura will talk a little bit more about moving forward, that it was clear that we needed to sort of think about that as a scientific endeavor. So we developed a core working group as well as a larger group, and really wanted to consult with experts to understand how we should move forward. And the first group of experts that we wanted to approach were people and the public and community members. And I'll just, give a nod to Janine Paul, who was head of our public engagement office at the time, who really pushed us to say, this is the most important thing we need to do right at the onset. And she was right. And so we convened something called the People's Panel, with partnering with Tamarack and the Digital Justice Lab, and convened 54 members of the public. Some of them were members of our Public Advisory Council, to help us think through, what would some of the approaches and principles be for this framework. And that really, laid the foundation for the principles that we developed. There's a document on that. We've heard from some of them in a webinar. So for those of you who are interested, please, we can put the links to those in the chat. And then we consulted with many other experts, both internal and external to ICES, and we're really incredibly grateful, for all the advice that we got. So, our thanks to so many who contributed. Two other comments just around context. We we weren't starting from scratch. So we drew on our experience in developing this framework from the work that we've done with First Nations, Métis, and Inuit partners to develop approaches and policies for the governance of their data. This is a distinct, I would say, area that really aligns with the importance of their political and sovereignty and the data sovereignty that comes with it. So this framework is not about that, but we do have that distinct framework. But we certainly drew, as did the EGAP framework, from a lot of the principles around that. And finally, I would say, some of the areas that we're really most excited about and think are so feasible for us as we move into implementation is really around community access to data. And so we have a funding stream from the Ministry of Health that allows us to do data analytics and research for what are called health system stakeholders, knowledge users. And this is a really good vehicle for community organizations to be able to access and request data analytics. And so we're building on all of this as we start to move forward. So with that, I'm going to pass on to Laura, who will give a little bit more detail around other aspects of the framework and how we are moving forward.
Great. Thank you so much, Astrid. And thank you again, everyone, for joining today. I'm pleased to be able to now provide you with some more information on the guidance document itself, dig a little bit deeper into some of the foundational work that Astrid has just alluded to, and then look into some of the opportunities and challenges that lay ahead with implementation moving forward. Next. So before diving into the content of the presentation today, again, and really kind of echoing some of what Astrid mentioned, is that I would be remiss if I didn't thank and acknowledge all the work of so many folks who've contributed to the document development over the past 2 years. So although we officially launched this document on September 19th, there was so many kind of key milestones in development that were made possible by a lot of internal and external staff, scientists, equity experts, and members of the public, which I'll talk to in more depth in a moment. All this to say that we give sincere thanks to all those who have dedicated their time and expertise to this work, and we look forward to sharing it with all of you today. Next. So now we'll dive a little bit deeper into some of the key highlights from the guidance document and framework, tell you a little bit of what you can find inside, and then we'll look a little bit deeper and break down each of the framework domains and some of the actions that are required. Next. So as you can imagine, and as well as Astrid alluded to, there was a lot of foundational work that supported the early conceptualization of this document, both by present and past staff as well. And two kind of key foundational works that we want to highlight are, again, the work of the Indigenous portfolio at ICES and the Black Health Equity Working Group. Internally, we want to highlight the work of the ICES Indigenous portfolio, as well as their partnerships with Chiefs of Ontario and Métis Nations of Ontario. So ICES has developed distinct approaches and policies for Indigenous data governance in partnership with First Nation and Métis leadership to ensure appropriate data use. The framework we will discuss today was informed in part by the ICES Indigenous Data Governance Principles Framework, which you see here on the left-hand side of this slide, which was developed in collaboration with the Chiefs of Ontario, and again, the ICES Indigenous portfolio for First Nations data and research. So given the distinct approaches required and existing work underway, the guidance document we discussed today does not address Indigenous identifiers or data within its recommended actions. However, we strongly encourage you to visit the ICES Indigenous Portfolio webpage on our website to learn more about their work that is underway. Externally, also as Astrid mentioned, another key document that helped shape the foundation of this work was the Black Health Equity Working Group's Engagement, Governance, Access, and Protection Framework, or EGAP framework, describing governance needed for the collection, management, analysis, and appropriate use of data specifically for Black communities. The creation of the ICES guidance document and framework was in part to address the EGAP recommendations and the call for research institutes to improve data collection, use, and governance. We recognize the importance of both these initiatives as a key starting point for our own work. Next slide. So before we dive into the document, I also want to acknowledge and highlight ICES's general position on racism and the use of race and related data. First and foremost, as an organization, we want to acknowledge the historical practices that may have contributed to unintentional harm or further inequity in research. Moving forward, we also acknowledge that systemic racism exists and has direct impacts on health systems and communities. We encourage the use of race and related data to address inequities, but when used in a way that reflects the values and perspectives of communities and acknowledges the impacts of systemic racism. Although ICES believes in investigator-driven research, we also understand and emphasize the importance of data controls and organizational values upheld for all our ICES research. Next slide. So now diving into the document itself, really the guidance document and framework outlines our path forward with organizational approaches that support research that uses and governs race and related data appropriately. So there's two main documents that you may have already reviewed. We have the full document and framework, and then we have the short, more concise executive summary that you can also view. I'm going to describe a little bit about the principles for appropriate use for race and related data that you will see introduce the document. And then as well, we'll dive into the framework itself and the corresponding actions. Next slide. So within the beginning of the guidance document, you'll see the principles for appropriate use of race and related data, which was informed directly through the work of our ICS People's Panel, as Astrid mentioned. So just recapping, again, back in spring 2021, ICS worked with the Tamarack Institute and Digital Justice Lab to lead a People's Panel that was composed of over 54 members of the public to advise ICS on approaches to using race and related data for health research. And through this People's Panel, we really sought to hear directly from members of the public, especially those who identify as racialized, to understand their priorities and values for how these data are used and interpreted as we go forward. The result of the People's Panel work were 10 principles that informed our framework and direction moving forward. The principles themselves are included in the guidance document, as I mentioned, and they're also organized by ICS values. They also include example guidance for application that's further supported by the Canadian Medical Association Journal and their guidance on the reporting of race and ethnicity in research articles. I encourage you to access the full summary of the People's Panel work, which is under our Health Equity tab on the website, as well as about a 60-minute video that summarizes the work from the People's Panel from the members themselves. Next slide. So diving into the framework now. So this is the framework to drive anti-racist approaches to health research at ICS, and it has those 4 key domains that Astrid mentioned. It also has specific components under each of those domains that we commit to going forward, which I'll talk about next. And you can see the principles for appropriate use of race and related data really make up the foundation of this work. Next slide. So from here, I'll break down each domain of the framework and talk a little bit about some of the short-term actions that are already underway, as well as some of the challenges for implementation moving forward. Next slide. So the anti-racist research domain is all about community-informed, multidisciplinary research that is executed with an anti-racist and equity-focused lens. So there are 3 key components you'll see of this work. Number 1 being that we build internal capacity through tailored resources for our staff, scientists, and trainees to understand and use race data appropriately. Secondly, that we broaden the expertise at ICS through collaboration with social scientists and equity experts. And then the third being that we ensure transparency around the data quality and the method of data collection or acquisition of the race and related variables that already exist in our data repository. So to achieve these actions in the short term, we've recently launched a revised internal resource list available online for our staff, scientists, and trainees that includes tools, external trainings, as well as internally created resources to help guide health equity work, and also a section that introduces community engagement and how you may begin to consider this in an ICS project that uses race and related data. In addition, a comprehensive assessment of the source, so in other words, was the data self-reported? Was it socially assigned by something like a clinician report? of all the race and related variables in our ICES data holdings was completed. We refer to this as a data inventory. So providing the source will not only help our scientists accurately describe the data in reporting, but it will also help them to reflect on any potential biases that exist in the data collection. There may be situations also where socially assigned race could offer value, especially if there's only limited data available or if it can be an appropriate proxy for experiences of racial discrimination, for example, differential treatment by care providers. This is also why we have offered more transparency around the source of the data collection, and will continue to do so moving forward. However, the challenge for long-term implementation will really be that piece on broadening expertise through establishment of sustainable collaboration with other folks like equity scholars and scientists, including in other disciplines. To sustain change efforts long-term, it's really important that we create that institutional knowledge, engage with a wider scientific community in health equity research, and really support mentorship and capacity building opportunities as well. However, there will also be resourcing and funding structures that must be considered to help support these scientists to access and use ICES data and/or collaborate on existing projects. And it's something that we need to continue to plan for in the coming months and years ahead. Next slide. So the community access domain is focused on creating pathways for community organizations that serve racialized and equity deserving groups to use our applied health research question program that Astrid was mentioning and have supports for these services. So within the domain of community access, we want to focus on two main components. So one, increasing awareness of our ICES data and analytics services through the applied health research question or ARC program. And two, building mutual capacity with community, understanding the contextualization of the data and providing tools to support using the results. In the short term, many community organizations are currently not aware of the ARC program or potentially ICES as an organization. So we're in the process of creating more tailored tools for community organizations to explain the ARC process and what it can and cannot be used for. We are hoping to also gain insight through community consultations with groups who have used the ARC program, as well as those who have never used the ARC program, to help co-design these materials and ensure the content is tailored to the audiences that we want to reach. Of course, there are challenges ahead as we continue to create awareness of this work for community organizations serving racialized and equity-deserving groups. We want to ensure we have the proper resources and funding to support this work going forward, especially if there is an influx of projects that must be balanced with our existing priorities. We must also ensure that we have adequate staff support for groups that may be new to the ARC program, and something we need to continue to allocate and budget for as we move forward. Next slide. So the community governance domain is focused on ensuring we have a structure to guide how communities can be involved in governing their data. So there's one main component under this domain, and that's really to plan and consult on the best path forward for establishing a structure, as well as potentially an advisory table to guide this work at ICES. As mentioned, this domain is distinct from the Indigenous data governance structures already established and in place at ICES. So in terms of short-term actions to address this core component, we've started initial consultations with community members and organizational representatives to understand a little bit about how ICES should begin to envision this work and some key values to consider as well. However, we will need to continue this work to collaborate with partners to determine a plan forward that is led by ICES but heavily co-designed by communities. The challenges ahead will be balancing the needs of communities with investigator-led research that still fosters scientific independence. Consultations as part of our community governance mandate, planning, and structure will not only involve community members, but they must also involve governance and data leaders to begin to envision the best path forward that considers the importance of both perspectives. Similar to our Public Advisory Council, which functions as a liaison between ICES and the public voice, we envision a governance advisory group functioning in a similar manner to advise on key considerations when using data that impacts communities. At the end, there must be a balance between data experts and the community voice that works in tandem, and something that we will need to explore further in this work. Next slide. Finally, the accountability for impact domain is focused on mechanisms for evaluating and really maintaining transparency of these efforts moving forward. There are three key components under this domain. That includes, first, thoughtful consideration of how to mobilize and continue to actually share research results back to communities whom they impact. Second, transparency and remain transparent on data use. And then third, having mechanisms in place to successfully measure the success as well as the challenges to the ARC program use by community organizations. In the short term, we've been increasing accountability of our data algorithms, including those that may assign race and ethnicity based on other variables. The discontinuation and increased control over the use of these data has been part of ensuring that we're using the data we do have appropriately and thoughtfully. Now, as we continue in our evaluation and monitoring, the challenge will be in establishing mechanisms to measure impact of our efforts across all the domains of the framework, to understand the nuances of when data is being used and how, not only for transparency, but also to identify areas where future capacity building internally is needed. Measuring impact over the long term will be a greater challenge to ensure the efforts are sustainable as well as ongoing. Next slide. So as I kind of get ready to conclude, I wanted to talk a little bit now about the broader implementation of the document as a whole. We've broken this down by domains of the framework, but now let's dive a little bit deeper into some of the considerations over the long term. Next slide. So there's 5 key points that I want to dive a little bit deeper when it comes to implementation and long-term action. So first on the slide, we really have to consider how to establish meaningful relationships with communities, leaders, and equity experts, and build trust really from the ground up. This is something that will take considerable time and effort, as well as really a meaningful acknowledgement of the groups we wish to involve. Second, we really need to consult with data experts and community members on many larger implementation plans and continue to do so as we move forward. Consultations also include ongoing temperature checks with our ICES community of staff, scientists, and trainees to ensure that our efforts are also meeting their needs, they're having an impact, and overall they're clear. In particular, the conceptualization and co-design of community governance structure is an example of a strategy where more consultation and more effort will be required going forward. We also need to think about how to ensure our implementation is evaluated and monitored on an ongoing basis throughout this journey. This includes both formal feedback, as I just mentioned in the previous slide on accountability, as well as informal feedback from our partners that we're working and building relationships with. And finally, we understand that this is an ongoing opportunity for learning and growth. And the release of the guidance document and framework really just marks the beginning of the work going forward. We will continue to adapt to the changes and the needs of communities as well as the organization. Next slide. So really on that note, the guidance document and framework is very much a living document and will be updated periodically in response to any ongoing organizational learning as well as evolving community needs. But I did want to mention that existing already on our website where the guidance document currently lives under the Health Equity tab, there is a perpetual feedback form where you can submit thoughts, things that you may want to see changed in future iterations, and we welcome all your feedback. Slide. So with that, I have our department's email as well as my own email. If there's ever any questions or things you want to dive deeper in, welcome those queries. And really with that, I'm pleased to now hand it over and introduce Dr. Arjun Siddiqui, who will share broader insights around the collection and use of race and related data and research. So thank you.
Thanks so much, Laura, and thanks for having me here today. Great to be with everyone. I'm just going to talk a little bit about some sort of basics and context around race and health and where the data fits in. I just wanted to make note of the context coming into COVID for studying race, racism, and health in Canada. These are just some sort of anecdotal feedback that I've received, that other colleagues of mine have received. And I just wanted to put this out there to give you a sense of what the landscape looked like once upon a time, not too long ago. So a colleague of mine who is one of the world's foremost leaders on studying race and health actually had a major federal award rescinded or not renewed at least when he received a reviewer feedback that said it's racist to study race effectively and that that's an American thing. Very often you would hear it's not race, it's immigrant status or it's socioeconomic status. Also, a common refrain was, do we really need data? Do we really need to document what people already know is happening? And finally, you would also often hear, okay, but what's the intervention? So if it's race, that doesn't really help us effectively because we don't know how or where to intervene. And I hope that over the course of my talk and happily in the Q&A, we can talk about some of this. So let me talk a little bit about race in the time of COVID and pick up where Astrid left off, actually. In the Globe and Mail, as COVID-19 and the pandemic were ramping up, there was an article about how racial disparities in COVID outcomes were already being noted in the United States. And here we were in Canada with no data to inquire about whether we were seeing similar disparities. On the other hand, in the news, there were a lot of anecdotal stories coming out that sort of suggested that there might be a pattern here too. These are 3 of the first documented cases, all Black and brown people, all people who were essential service workers. So amongst the first deaths reported by the media. Many of us started writing about the fact that not having the data is really hindering our ability to say whether or not the pandemic is unfolding in unequal ways, and it appears, the signals appear to be that it is, and it's really an injustice that we don't have the data. And at the same time, there were provincial leaders who were effectively saying not only, we don't have the data, but actively saying we don't want or need the data because in this case, we all care about everyone equally, which, I'll leave that for you guys to discuss. When the data first started coming out, as Astrid pointed out, there were sort of a series of people and events that led to data coming out for COVID testing and eventually for other COVID outcomes. This is the kind of graphs that were produced by Toronto Public Health, and many of you may have seen them. In the green bars are the proportion of each racial group in the city of Toronto, their proportion of the population, and in the gray bars, the dark gray, are the proportion of COVID cases in each racial group. And you can see that from left to right, a lot of, if not most, non-white groups, particularly Black people and South Asian people, were vastly overrepresented as a proportion of their own population amongst COVID cases. True also for Latin Americans, and whites were underrepresented as a proportion of their population. Then came the sort of consternation about why this might be. And as Astrid pointed out, there is a large sort of biomedical complex that traffics in understanding race as a genetic construct. In fact, this is a CBC article in which a major figure in Canadian health questions the data that's appearing to show the disproportionate effect of COVID on Black people and says, I wonder how much of this is socioeconomic and how much could be genetic. So it's sort of like, I bet it's kind of both, which it is emphatically, it is emphatically not. Let me give you just 3 examples to show you why and how we know race is not genetic from some sort of contemporary studies. So this is a study that looked at Pima Indians in Mexico and Arizona. So the Pima Indians at some point in history had their society bisected by a political border, but this is the same group and a fairly homogenous group in Arizona and Mexico, and yet In Mexico, Pima Indians have 6.9% proportion diabetes compared to 38% in the US. So very difficult to ascribe a genetic cause to a common group having vastly different outcomes in different countries. This is a graph that shows the distribution of birth weight for 3 populations. One is the birth weights of moms in the US who were born to African-born immigrant women, meaning women who had born in Africa, had immigrated to the US and gave birth in the US. US-born moms who were Black and US-born moms who were white. And the 2 distributions that most overlap each other are the African-born moms and the US-born white moms. And it's the US-born Black moms that are shifted to the left. And that indicates that 2 groups who we think of as being the same race, the African-born Black women and the US-born Black women, have very different outcomes. Ergo, genetics is a very difficult causal explanation for that data. Even within the same racial group, you see a lot of change over time. This is a graph that shows birth weight trends over time in Japan. So you can see in 1970, birth weight started higher and has descended over time. A relatively homogeneous population, not a lot of immigration coming in, and yet birth weight has changed substantially over time. So this idea that both race is genetic and that these outcomes can be explained by genetics is fairly misguided. So what are we talking about with race and health? I think, preaching to the choir, so I'll go through this fairly quickly. But effectively, race is a social construct, but what that means is that societies create social categories. There's no natural racial grouping that we can ascribe to the human population. We decide what characteristics constitute social groups, and we do it because societies that have groups that are in power and have resources want to find ways to hoard that power and resource, and race throughout time has facilitated the ability to keep power and resources concentrated amongst whites in particular. And so because of that, racial groups have very different experiences related to health, different levels of material resources, different levels of stress, different levels of access and opportunity, and that inevitably affects health, as we know social determinants do. So let me just sort of quickly go back to the matter of racial disparities in COVID that I alluded to earlier. Starting on the right, the sort of social power resource explanation for why we had racial disparities in COVID has to do primarily with the fact that racial groups were more or less likely to be essential service workers and therefore to have to go to work and be exposed at work. Why? Because racism in the education market, the labor market, and so on kind of force some racial groups into jobs that are riskier, and other groups have the privilege of being in jobs that are sort of safer. And in fact, they tend to be riskier for a range of diseases. In this case, they were riskier because you're more likely to be exposed to an airborne virus. But the same jobs are also riskier because they come with low pay and they come with more stress and so on. So on the one hand, this is about equity and inequity, but it is important to also understand that the matter of understanding race in relation to health can also be about how population health is fundamentally distributed. So I'll come back to this graphic where I said, you can see that non-white groups, particularly Black, South Asian groups, are overrepresented as a proportion of their population. But it's also the case that non-white groups in absolute terms were more likely than whites to have COVID. So in Toronto, they accounted for 70, sometimes 75% of COVID cases, depending on the time in the pandemic. And so if you have a distribution that is accounted for by a variable in that way, so that 75% versus 25% explains what's happening, that means that you have to understand that social distribution to understand the population health phenomena itself. And again, this was very intimately related to the fact that COVID was spreading through people who had to go to work as essential service workers. So that was a major mode of spread, and that's why race was so salient. It's because racism and the labor market were so salient for this outcome. So it's almost like you can't understand not only health equity, but even population health without understanding its social distribution. And very often that social distribution happens across racial groups, precisely because race is a primary way that we distribute life and life resources and life experiences. So what good is the data? I mean, maybe we already know all of this. Maybe we don't need to know anything else. Well, I tend to think that we do, and there's several reasons for that. I can talk a little bit now about the implications for what we can learn. And often people worry about what we're going to do with this data and whether interventions are going to transpire. And I think that's a very, very reasonable worry. I have to say, I am also of the mind that we have to know what kind of society we live in. So if you were to ask me as an individual, I would tell you that we need this data and this science simply to document our society and what we're doing to people over time. This is a slide that just gives you an example of what happens when you have race data over time. This is from Nancy Krieger and her colleagues, and they track cancer rates by race and socioeconomic group over time. So they know not only that there's inequities, but how those inequities are changing and what those inequities might respond to, what kind of societal conditions may be happening that make those inequities get worse or get better. This is a slide from the US where they have a lot of race data, so they have a lot of information that shows racial differences in unemployment rates. And it was really interesting over the time that Obama was president, over the time that Trump was president. You know, there was a lot of talk about the fact that unemployment rates went down in both cases. But it was also true in both cases that inequities didn't budge. So across time, there's this really stubborn phenomenon that even as things get better for everyone over time, the gap between groups tends to maintain itself. And that's the kind of stuff we can only know if we have the data. This is an example of a graph that I thought was fairly compelling, where I think Public Health Ontario here had documented COVID tests completed, and they had other outcomes for kids in different age groups. And they superimposed on that different events, school closures, school openings, and so on. And imagine if we had that data by race. You could start to see whether some racial groups are benefiting or being harmed by quote unquote interventions or events or policies more than others. I'm just looking at the time, so I think I might just skip the last slide. It's just to tell you another example that if you can understand equity over time, you can see what it responds to and what it doesn't, and what societies do that support some groups more than others, and therefore intervene accordingly. So let me pass it over now to Sujita for the Q&A. Thanks very much.
Thanks so much. And first, I want to start off with thanking our speakers. So Michael, Astrid, Laura, and Arjuman for really walking us through the impetus for this work, providing an overview of the framework and its development, and then, of course, why this work is important and considerations as we look forward. So now it's over to the audience for questions. And we have a few that have come in already, so I will get to them just given our limited time. So the first one I'm going to pose to Astrid to start off with, and then please feel free to jump in to the rest of the panelists. When working as a provincial level organization primarily, how do you balance the differing needs and experiences of urban or GTA racialized people compared to rural or northern groups?
Thanks. That's a great question. And I think it depends on what the kind of study or analytics that would be required. I mean, I guess the first thing I would say, and this is what this whole conversation about, is the more disaggregated data that we have, the more you can speak to how different contexts affect um, different populations. So that's kind of at the study level. And the other piece is, a big part of that context is if you're doing work around what urban populations might, what might be happening in urban areas versus rural. I mean, we tend to think, we do a lot of health system work, so we know that access to care is very different. Like the more you understand, all of those contexts, as well as, different populations who experience different things in our society, going on, following up on what Arjuman was talking about, that's important. If it's more a question around how do we as a corporate entity prioritize work, in one area or the other, I mean, we basically, in terms of independent research, it's really what our scientists are bringing grant money in to study. But in terms of the ARC program, so that's the program where knowledge users can ask questions, we don't differentiate or prioritize some work over others. So just because Toronto has, millions of people and Thunder Bay has fewer, doesn't mean we won't do work for Thunder Bay. So our prioritization has a lot more to do with whether the question is feasible, et cetera. And then the last question, and I don't know if this is where it was going, is, for us to run data, like, whether you run it on a small population or a large population, it's actually not much more analytic work. And so a lot of times, we also try to leverage work that's, especially for the ARCs, if we've done work for one community, and this was certainly during COVID when we did so much work for public health units and very locally specific, if we're doing work and we've done the work to understand how to measure something, it's not that hard for us to then do that for another region, another organization, et cetera. So that's kind of one of the beauties of, the work that we do institutionally. So I hope I've answered the question, but if not, please clarify.
I think you have, and I'll just give an opportunity to any of the others that if you want to add anything. Okay, great. So on to the next question. And this one I think might be best suited for Laura to start off with. What kind of internal resources are being contemplated for ICES staff and researchers, and will they be made available to the public as well?
Great, thanks. That's a great question as well. And I know especially a lot of organizations are looking into making a similar kind of resource list. So I'll just give a little bit of background on how we came about this. So it actually started last fall. We released a survey to our staff, scientists, and trainees, and just said, that people kind of knew about the guidance document, that it was coming, and we put a general survey out there to see what did people want to learn about or what did they want to know more about. We were also focused on that community engagement piece as well, wanting to know if there are specific things that we could pull together related to community engagement. So what we really heard from that survey is that people wanted very tangible things. They wanted trainings that already existed on health equity and using race and related data. They wanted tangible tools that they could use in their research. And then they also wanted kind of ICS specific examples or resources as well. So we really use that as a guide to help us craft our own kind of internal web pages. So we exactly that, used those headings, took note from a lot of great organizations that are putting out amazing trainings and webinars and started to pull that together. And I think, as I alluded to in our presentation, we also made a guide for community engagement specifically for ICS projects. Now, understanding this is just kind of like a first step into this one initial guide, but we do plan to kind of expand on this work going forward, hopefully also have kind of more one-on-one consultation opportunities as well for staff or scientists who are interested. And then in terms of making it publicly available, great question as well. I think, again, a lot of these external sources that we've started to pool together, they're not currently on our website, but this is something we've also been talking and discussing, potentially even including all the amazing papers that have been conducted by our own scientists in this area and how we can kind of put that on our website and make it more available. So hopefully that answers that question.
That's great, Laura. Thank you so much. And I think we have time for one more question before we sign off. So the question came in, and it's, can you please expand on race and genetics? And I think, Arjuman, this is related to some of the aspects of your presentation. While there are many environmental factors that contribute to health, including racism, can we completely dismiss potential genetic effects?
Yeah, thanks, Sujita. The answer is yes, we can completely dismiss them, and I'll tell you why. And there's maybe a couple of isolated cases where the gene of the disease coincides with what we use to characterize race, but that's more coincidental. So there's a few reasons we can completely dismiss it. One is that there's no genetic basis for the category. So it's really difficult to ascribe something to a category that's not built on that at all. So if you look at racial categories over time in different places, the same race, or a race that we perceive here will be called something else somewhere else, or will be categorized differently. So what is white and what is black can change over time. That's because we just kind of make decisions over time about who is black and who is white. And if you go back to census instructions from the 1800s in Canada, they say things like, well, this person is yellow and this person is, et cetera, et cetera. So we know that there was no genetic basis for what categorized people by race in the first place. That's one thing. There are population genetic groups across the world. So it's not that there's no rhyme or reason or order or difference at the group level in genes, but what population genetic groups are just don't correspond to racial groups. So within the Black population, you have tons of population genetic groups, and some are closer to European groups. Others are very distant from European groups. So in fact, the genetic distance between two Black people can be larger than the genetic distance between a Black and a white person. So it's just, there's so many entry points to show that genetics are simply not the reason that racial groups differ. Now, there's one other way that sometimes it looks like that, which is that when you look at Europeans and Black people as a whole, Black people as a whole is a very large genetic group because it's where we all come from. So if you're looking at European ancestry, then you've got a very small component of the global genetic makeup. It's one that Black people may overlap with, but a lot won't, or a lot of Asians won't, et cetera. So everyone could overlap, but then you have a much larger sort of set of genes that won't be represented by a group that it has a small kind of geographic footprint in the world. There's one more thing to say, which is I mentioned there's a couple of small exceptions. So skin cancer is a small exception because the genes that predict, essentially you are more at risk when you don't have as much melanin in your skin. And melanin is also a way that we group races. But that's not, so in other words, skin cancer doesn't happen because of race per se, but there's this coincidence that we use melanin to judge race and it's a factor in producing skin cancer. So, we use other characteristics to categorize race too, like hair texture, that tend not to have any kind of coincidental relationship with, like genetic coincidental relationship with health. So there's a couple of small exceptions like that, but by and large, the more you dig into the genes, the more it's going to show you that it's not genetic.
Thanks so much, Arjun, for answering that so clearly and giving us some examples as well. And I think we have time for one more question. And it's in the US, we see that disparities increase despite the collection of race-based data. How do we ensure the data is used to generate solutions that are led by communities? And I'll turn that over to maybe Astrid or Michael if you want to start off.
Yeah, I'm happy to start. I think I have a lot to say on it. It's an excellent question. So one is you have to involve communities. I mean, they will be the ones that may be best suited to advocate for what they need. But if you listen to argument, I mean, these are like massive societal influences, that relate to how what we our immigration policies, our labor policies, so I think to assume that data is going to fix all that quickly, I mean, that would just be naive. But the more we can, I think, put data in the hands of people who may be able to make change, that's one good step. And I think the other thing too is a little bit around capacity building. And I say this having done some community-based research that, there is sometimes research funding. Research funding can fund interventional research as well, because we're really talking a lot about observational research. And that sometimes can also get the ball rolling. But I think the piece then around how that rises to the level of the kind of change you need to see to address some of these underlying things, that's a huge question. And that's like, to me, that's a societal question. And research can help it along, and communities and effective, I mean, if you have people like Cindy Blackstock, you need people like that to make change. But the analytic part, it's one piece, but then there's just this whole other piece of which there maybe is some more research in there, and then the rest is what people do with that. But certainly a first step is making sure that communities who need data to advocate and need data to reorient services, that's an obvious kind of first step.
And maybe I'll just add, clearly having the data itself is not the solution. That's a necessary but not sufficient condition. And I think I would argue that, in the US, for example, where there's been race-based data for a lot longer, it's been more broadly available. I think some of the insights that Arjun was talking about how race operates was not necessarily as widespread or as well understood. And so I think obviously you need more than just the data itself. And I think that's what we're trying to develop here, is an approach that will both bring increasing amounts of data, but also those kinds of insights and the kind of community engagement that Astrid mentioned. At this point, I think I'll just wrap up. We're now at time, and I want to just say how terrific this conversation was. I want to thank our speakers, Astrid and Arjun and Laura and Sajita, for managing the Q&A. I'll just underline, how important this is to our organization to get this right. Health equity is a key pillar of our strategic plan. Understanding race and ethnicity as drivers of health outcomes and health inequities is critical to us achieving our mission as an organization. And we're not going to do it by ourselves. We're going to do it by engaging with communities, engaging with the wide array of publics out there in Ontario and beyond, and of course with a broad scientific community to advance these questions. So thank you again for joining us today. I anticipate there are going to be more events like this coming. Please stay in touch with us, follow the further evolution of this framework and its operationalization. And we really welcome your comments and feedback on this event and the next steps in this important area. Thank you very much.